are recording this presentation tonight, everybody. We are just letting everybody in here. Okay, I think we're going to get started, right? We're going to just kind of jump right in, and if more people come in, we'll have them come in as they join. So good evening. We're super excited to be here with you. This is a Cancer Bridges gathering place, get together, collaboration. Susan, I'm just going to throw it over there to you to maybe introduce yourself and gathering place, and then we'll come back to me and go from there.
Absolutely. So my name's Susan Marinac. I'm from the Gathering Place, so those of you that are from the Pittsburgh area, we are like the Cancer Bridges program, but in Cleveland. And our mission is to provide a caring community that supports, educates, empowers individuals and families currently coping with the impact of cancer through programs and services. We very much enjoy working collaboratively with Cancer Bridges, and this is our second joint program. And we are very familiar with Dr. Schmitz's research, and we are a part of it and happy to do that. I just wanted to thank our leadership team and our marketing team at the Gathering Place. And a huge thank you to Cancer Bridges, of course, for the continued collaboration. And a big shout out to our exercise team at the Gathering Place, Stephen, Jenna, and Sandy. And in addition to the virtual program tonight, we're having some in-person programming at our East and West locations as well. And we are continuing the fun with parts 2 and 3 of Moving Through Cancer. And we have 2 more programs in the upcoming months at the Gathering Place talking about exercise, the importance of exercise in cancer rehab. So that's it. Thank you. Enjoy the program, and very, very proud and happy to be here.
Thanks, Susan. And I'll introduce myself. I'm Colleen Dwyer-Deal. I'm one of the clinical managers here at Cancer Bridges, and I'm sitting next to the other clinical manager, Wendy Myers. And we're super excited to be here with you. Our mission here in Pittsburgh at Cancer Bridges is to provide free programs to all who've been impacted by cancer. So our cancer diagnosis. So from diagnosed to caregivers and supporters to kids and families and bereaved. So please check us out if you haven't already. And I'm just going to jump right in to introducing Dr. Schmitz. One thing I am going to just ask all of you, if you don't mind, is if you would mute yourselves so that during the presentation we can hear Dr. Schmitz. So here we go. Dr. Schmitz is a professor in the Division of Hematology and Oncology at the University of Pittsburgh School of Medicine. She serves as the Associate Director of Catchment Area Research, co-leader of the Biobehavioral Cancer Control Program, and Director of the Exercise Oncology Initiative for the Hillman Cancer Center. Dr. Schmitz's research focuses on people living with and beyond cancer and investigates the role of exercise in improving physiologic and psychosocial outcomes, including systems, treatment tolerance, and other chronic disease. In addition, Dr. Schmitz studies technology-based supportive care interventions that include physical activity to improve outcomes among advanced cancer patients. Her well-regarded research on resistant exercise and breast cancer-related lymphedema has been translated into a physical therapy delivered program called Strength After Breast Cancer that is available in over 1,000 locations across the United States and beyond. Dr. Schmitz was the following force behind 2 American College of Sports Medicine development processes for exercise and cancer guidelines for patients in 2010 and 2018. She founded the Moving Through Cancer initiative of the American College of Sports Medicine, which has a bold goal of making exercise standard of care in oncology by 2029. She has written a popular press book to raise awareness about exercise for cancer patients and survivors entitled Moving Through Cancer that was released by Chronicle Books in October 2021. She is the winner of numerous awards, most notably the Distinguished Scientist Award from the Society of Behavioral Medicine, the Citation Award from the American College of Sports Medicine, and the Clinical Research Professorship from the American Cancer Society. So welcome, Dr. Schmitz. Thank you again for being here with us this evening.
Thank you so much for the invitation. I'm delighted to be with all 52 people who are, online, and I think this is getting recorded, so some folks might also listen. I want to give a particular shout out to Josie Van London, who I think has joined. Hello, Josie. I look forward to coming and visiting with you sometime soon. And to Stephen in Cleveland, who I get to work with on the Thrive trial. So nice to be with you all this evening. So I have slides that I'm going to go through. I'm going to try to share them now, and you'll need to let me know if you're getting my slides. Did they come through?
They sure did.
Okay, fantastic. So the title of my talk, and I think I'll talk somewhere between 45 minutes and an hour, but then we'll have, 45 minutes to 30 to 45 minutes for questions, but I'm so tired because, one of the very first things that happens in my conversations with people living with and beyond cancer is, cancer-related fatigue is such a ubiquitous issue in this population. And, when I say you really, you will benefit from exercise, what I hear a lot is, what part of I'm tired do you not understand? And, it's a difficult thing because it is very, very much a counterintuitive thing to say that being more physically active will actually help with cancer-related fatigue, but it does, in fact, do so. I point out in the bottom left-hand corner that I am quite active on Twitter, or whatever we're calling it these days, X, I think. It's called I'm at Fit After Cancer there, and on Instagram, I'm at Fitness After Cancer, so you can follow along with what I'm doing there. So as an overview of what we're going to talk about this evening, I'm going to introduce first a concept called exercise snacks. So you didn't know it, but you're going to exercise tonight. And then I'm going to talk about why you should exercise. Part one is about prevention of cancer. Part two is about exercise to address symptoms. And then I'll talk about a program that we run at the Hillman Cancer Center that I would love to see happen in other places as well. We'll do an extra exercise snack, and then I'm going to close with some inspiration from other cancer patients and survivors and what they've gotten done. So the idea behind an exercise snack is that we don't have to put on spandex in order to get ready to exercise. We can exercise right here, right now. And so we're going to do that. Exercise snacks is a concept of short bursts of exercise that you do throughout your day. If you feel overwhelmed and say, I can't exercise today, could you do 1 minute? 1 minute, that's it. So fun-filled, bite-sized exercise events. So right now, together, what we're going to do, if you are able, if you are somebody who can stand up, is you're going to stand up, and then you're going to sit down. And then you're going to do it again. Number 2, and sit down. And the third time, 3, and sit down. And 4, and sit down. And 5, and sit down. And 6, and sit down. And 7, and sit down. And 8, and sit down. We'll do 2 more. 9, sit down. And 10, sit down. Those are called chair squats, and they're incredibly important for maintaining your physical function. So, having told you about exercise snacks, what I now want to tell you about is exercise and cancer prevention. So the data that I'm showing you here is really remarkable data from Dr. Stephen Moore from the National Cancer Institute. These data were published in 2019. These data were published in 2019, And what they did was they gathered together the cohorts from across the North America and European cohorts, and they had over 1,440,000 cancer or individuals followed to see whether or not they developed cancer. And they had physical activity data. So they looked at how much physical activity these people did, and they followed them over time to look at incidence of cancer. And so you can see the laundry list of cancer types that were studied and which were found to be reduced incidence if the person was more physically active. So just to orient you to this slide, a hazard ratio means a hazard ratio of 1 means that physical activity does not help at all. Okay, if the hazard ratio was on the positive side, above 1.0, it would mean that the exposure, whatever the exposure of interest would be harmful, would cause cancer. But what you can see is that in all of the cases of all of the cancers listed on this slide, the incidence of cancer was reduced in the patients who are the people who were more physically active as compared to those who were less physically active. The other thing that is important here is I note for you that there are purple squares and black squares. One of the things that might be asked in an epidemiologic study looking at physical activity and cancer prevention is, yeah, but isn't it just obesity? Isn't it just really about obesity? And the answer here is no. So what we have are what the hazard ratios looked like before adjustment for body mass index, and then what the hazard ratios look like after adjustment for body mass index in black. And you can see for most of the squares, the distance between the purple and the black squares is very small, and there's still a statistically significant reduction in risk for all of these different kinds of cancer. The one cancer for which that was not true, not surprisingly, is endometrial cancer, which is so heavily weighted towards risk because of obesity. We also have epidemiologic evidence, observational evidence, that tells us that we have reduced risk of cancer-specific mortality and all-cause mortality for people being more physically active in 3 very specific types of cancer: breast, colon, and prostate. And the magnitude of the reduction in risk from cancer-specific mortality for being more active is on the order of about 30 to 35%. That's a lot. That's a lot. Think about the margins that we use in, would we choose to do chemotherapy A versus B? And the differences are sometimes in the single digit frame of reference. And this is a very, very large decrease in the likelihood of cancer-specific mortality for those who have had these 3 types of cancer, for those who are more physically active compared to less physically active. So why? That's got to be a question on your mind. If we believe that physical activity has an effect on reducing risk of having cancer in the first place, or reduced risk of recurrence or mortality from cancer, then the question would be, well, what would be the mechanism through which that would occur? There are a number of studies that have summarized this information, and we certainly know that physical activity has a positive effect on our immune systems. That is enormously important to cancer risk, both initial occurrence as well as recurrence. We know that exercise has a powerful effect on our metabolism, on tumor physiology, on signaling, cell signaling between the cancerous cells and the non-cancerous cells, on gene expression, and on the environment of how we process free radicals and the kind of balance between oxygen-free radicals and oxidative stress. This review by Perya Hoyman in 2018 actually beautifully summarized all of why it is that we think that physical activity has the effects it has on cancer risk. The people on the left side at the top of the slide are a little bit pudgy, maybe, and we're noting that they have some metabolic disturbance and low-grade inflammation. And that is going to create a metabolic milieu that is a proponent for the development of metastatic disease. If, on the other hand, we start to do acute exercise, even a single bout of exercise has an alteration in natural killer cell infiltration, reduce oxidative stress, cell damage, and reduce metastasis. If we train on a regular basis, then our body habitus changes just naturally as a factor of being more physically active. This improves cytotoxic immune function and metabolic health. It changes the soup in which our cells are bathed in a manner that reduces inflammation and improves the way that our immune function works. It also improves perfusion to the cells of the body so that if there is a cancer, that the cytotoxic chemotherapies can be better delivered. The other thing that Dr. Hoyman summarizes in this very same review is what we know in animal models. Now, animal models do not beautifully recapitulate what happens in human beings, but we are able to do some things in animal models that we can't really do in humans, and that is to follow follow the animal from the point of, I have started exercise, to whether cancer develops or whether cancer progresses. That's very difficult to do in a human because it happens over the course of a decade or more. But in an animal, it can happen in a period of months. And so what we know is that there is a very reliable reduction in tumor growth in a broad variety of mouse tumors in both immunocompetent and immunoincompetent mice. You can see anywhere ranging from 31% all the way up to 67%. And this is a reduction in tumor growth as a result of giving the mice more exercise. So this is further evidence that exercise does have the effect that we see in the observational epidemiologic literature. So again, why? Why would this be happening? And one particularly brilliant study that I like to point out is from Carrie Shadler from MD Anderson Cancer Center. And what she was able to do was a 4-group study in animals in order to look at the issue of the tumor vascularization. And so what she was interested in was in the black line with the circle, no exercise, they did nothing. They just let the tumor grow. And then what happens if you just have exercise and no chemotherapy? There is a substitute growth of the tumor. If you give chemotherapy, which is the triangle line, then the chemotherapy does slow down the growth of the tumor. But interestingly, it is actually the combination of the exercise with the chemotherapy that results in the least growth of the tumor over time in the animal. And what's interesting is they did this in a melanoma model, and they did this in a pancreatic cancer model. And in both cases, it was the combined chemotherapy and exercise group that showed the least growth of the tumor as a result of doing that combination of exercise and chemotherapy. And what they were actually able to further see is that the reason this was happening was because of the effect of the exercise on the vascularization of the tumor so that the chemotherapy could get to the tumor. So there was a very clear mechanism for this to occur. So this field of exercise oncology is not brand new. This is actually not something I came up with this weekend and sat down and made some slides for you. This is something that's been around for a very long time. In fact, the first studies that we know of in the field of exercise oncology that are relevant to exercise oncology were in the year 1911. And there were animal studies back in the 1930s and 1940s, First human clinical trials happened in the late 1980s at Ohio State University. And you can see the progression from 1990 over time to 2017, when we did our, and 18, when we did our second ACSM, American College of Sports Medicine Roundtable. And if we look today, when we do a search of what's called PubMed, which is the place where scientists go to search for science, they go to look for the studies in their particular area. If I were to go there right now and put in search terms for exercise and oncology and clinical trials and English language, what I would find is that there are over 2,600 clinical trials that have been completed in the field of exercise oncology. If we include observational evidence, there's over 15,000 studies that have been done in this field. So not surprisingly, the field feels that we can conclude some things. We feel like we can say a few things about what exercise is capable of doing for you. And so there's a beautiful infographic that's available at the website that I'm pointing to here. But what we know is that exercise shows that we can help with a number of cancer treatment-related symptoms, principally cancer-related fatigue, health-related quality of life, physical function, anxiety and depression, sleep, breast cancer-related lymphedema in particular, and bone health. So I will take bragging rights for the work that I did that was important to change the landscape around breast cancer-related lymphedema. This work was done a very long time ago now, but before the PAL trial was completed, the advice that was given to women with breast cancer was to not lift anything heavier than 5 to 15 pounds ever again in their lives. I still hear that actually does, that is advice that's still given to women. It's a crying shame at this point. We were able to document with this trial that exercise is not just safe, but also quite effective for helping to reduce the likelihood of flare-ups of lymphedema in women who already have lymphedema and reduce onset of lymphedema in those who are at risk for lymphedema. So that program, I'm glad to say, has been translated into a clinical program called Strength ABCs. True story, we in the process of getting this program translated so that it could be available broadly, we did some market testing, and what we heard from patients was that they did not like the word lymphedema in the program, regardless of whether they had lymphedema or didn't have lymphedema. They wanted it to be called something more positive. And so Strength After Breast Cancer became the name of the program. This is something that is covered by insurance. It's available in over 1,000 locations across the US and beyond. There is a sort of a cottage industry out there of companies that provide continuing education credits for physical therapists to learn how to do various things. And one of those companies, called Close Training, will offer a training program for physical therapists to learn how to do this program for $125. I can tell you that I just finished in June training the physical therapists from the Rehabilitation Institute, which is the physical therapists from UPMC in how to deliver this program. So this program is now available in the Pittsburgh area. So not surprisingly, with all of this evidence base that I've been talking about, you won't be surprised to know that guidelines have proliferated. I wrote the first guidelines for exercise and cancer in 2010. We updated those guidelines from the American College of Sports Medicine in 2019. The American Cancer Society issued guidelines that came out about 2 years ago at this point, just slightly less than 2 years ago. And very importantly, the American Society of Clinical Oncology, which is the professional organization for medical oncologists in the United States and indeed internationally, published guidelines in 2022 indicating that medical oncologists should refer patients receiving chemotherapy to exercise programming in order to address common symptoms and side effects. Now, we don't know everything. There are still things that we need to study more. We certainly need more research on exercise and cardiotoxicity. after chemotherapy and radiation therapy. Chemotherapy-induced peripheral neuropathy is another area we need more research in. Cognitive function, falls, nausea, pain, sexual function, and treatment tolerance. I'm delighted to inform you that there is an NCI, National Cancer Institute, funded initiative called ENICTO, Exercise and Nutrition Interventions to Improve Cancer Treatment-Related Outcomes. And there are 4 large trials that have been funded in order to look at the effects of exercise and nutrition on treatment tolerance in particular. And I'm proud to get to lead the version of that is for older breast cancer patients, called Thrive 65. We're doing this trial at the University of Pittsburgh. We're doing this at Case Western Reserve. The Gathering Place is collaborating on this. Stephen and Sandy are 2 of the trainers for the study, and at Dana-Farber in Boston as well. Okay, we have a second exercise snack. So this one, you're going to stand behind your chair. And what we're doing is calf raises. So you're going to see me kind of disappear and reappear because of the nature of Zoom, but you're going to come up on your toes and back down, and a second time and back down, and number 3 and back down, number 4, I'm the invisible woman, 5 and back down, and 6 and back down, and 7 and back down, and 8 and back down. And I hope what I'm proving to you in doing this, 9 back down, is that exercise can happen anywhere, anytime. Okay, thank you very much. Take your seat. It doesn't need to be planned and in a separate room. Okay, so the research is a big woohoo because we know a lot, and we know that exercise is really good for people living with and beyond cancer. That's fantastic news. We've done a great job. We have come a long way. Now for the womp, 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 womp part of this talk. And that is to say that we're not getting it done. It's not actually happening out there in the world. 30 to 47%, sorry about that, of cancer patients are adequately physically active, and only 15% of patients report being referred to an exercise program by their oncologist. So that's why, when I was president of the American College of Sports Medicine, I started a brand new initiative called Moving Through Cancer. And the idea behind the Moving Through Cancer initiative is to answer the question then, what needs to happen for exercise to be standard of care in the setting of oncology by 2029? We had a retreat in 2019 prior to COVID. We brought together a medical oncologist, an oncology nurse, a physical therapist, a physical medicine rehabilitation physician, my dog, very important, my dog. And we spent 2 days answering this question: what needs to happen for exercise to be standard of care in the setting of oncology? And we published our agenda setting paper in 2021 to say to the world, this is what we think needs to happen if exercise is ever going to be standard of care. So the agenda areas that the team that came together, that task force came together to decide on, was policy. We needed policy changes. We needed funding and sustainability. We need program development. We need workforce enhancement. We need stakeholder awareness, empowerment, and engagement, and we need research and evaluation. So I'm going to briefly go through each one of these in turn with you. So in terms of policy, our biggest success to date is that I spent 2 years on the standards committee of the National Accreditation Program for Breast Centers. And I'm delighted to say that new standards from NAPBC, recently adopted, will require accredited breast centers to declare a plan for functional evaluations prior to surgery, which of course will lead to referrals to physical therapy, exercise referrals during the care of a medical oncologist, and exercise referrals at the point of survivorship. These go into effect in 2024. And you want to make sure that any cancer center that you are connected to knows that this will be a requirement for them if they are accredited by NAPBC. For programming, what we've been really interested in is figuring out how to get programming to cancer patients and survivors when they need it and where they need it. So we started by doing a landscape of what exists in the world of programming. We developed a program directory. We have over 1,800, actually, this is an old slide, it's over 2,000 programs at this point. We've mapped the programming. I'll show you the map in just a moment. We've identified gaps geographically. And we further are doing analyses to try to give examples of what good looks like. So there are a lot of hospitals out there that don't have an exercise oncology program or a robust exercise oncology program. Maybe they have a brochure that says exercise is good for you. But what does a program look like that's successful and that gets a lot of patients into exercise? So we're actually doing an analysis of that in order to publish that for clinicians to understand how to start their own program. We're also in the process of doing a robust cost analysis so that we can better understand how much it costs to run an exercise oncology program. And we will make that information broadly available on our Moving Through Cancer website. So here's a map of the United States with their exercise oncology programming. And there are a number of things to point out to you. The first thing is that there are black dots. Those black dots represent cities of 50,000 or more, just so that you understand where the population centers are. And then there's the red dots, and the red dots represent the exercise oncology programming. And you can notice a number of things. One is that there are great swaths of the west part of the United States that do not have any programs. There are places like here. This is a Live Strong program in Wyoming, Sheridan, Wyoming. And literally you could go all the way to the Canadian border, and you could go all the way to the south border of the same state. And look how far west you could go, and you wouldn't find another program. And so all of those people probably have no access to any kind of exercise programming at this time. This map does include cancer rehabilitation centers as well as exercise programming. The other thing, if you could zoom in, you could notice a number of things. One is there's a string of cities, 50,000 or more in California that are inland, that are not next to the shore, that do not have any exercise oncology program. The other thing you can note, if you were able to zoom in on the Northeast corridor, there's a lot that are right against the coast. But as soon as you get closer to Canada, then you start to have larger swaths of the country, and in particular in Maine, that have absolutely no programming available. So we have a long way to go with regard to making sure that exercise oncology programming is available where people need it. The other thing that we've noted, we've done an analysis of these data, of that map. We did a geospatial analysis, and what we're able to conclude is that 39% of the US population lives in a census tract that is more than 10 miles from exercise oncology programming. And the reason that's important is that, you know, a lot of people will travel 75, 100, hundreds of miles for just the right surgeon, right? And so, you know, they'll go a long way for great specialty care. But how far would you drive in order to go to an exercise class that would help you with your symptoms? You're not going to go 100 miles for that. You're not even going to go 50 miles. So we set the limit at 10 miles, and 39% of the population doesn't have any programming. We also noted in our analysis that there is a lot of disparities in the distribution of programming by population density. We noted, obviously, that there's less in rural settings, lower proportion of programming in census tracts with higher proportion of non-white residents. And that's kind of a convoluted way of saying that, you know, most of the programming is where most of the white people are. And then we also look at neighborhood deprivation index as a way of looking at socioeconomic status. And not surprisingly, there's less programming available in places with higher deprivation index, which means more poverty. So we do have this National Oncology Directory. The triage tool should be available in 2013. This is a very cool thing that we have developed. This is a way for us to ensure that when people go in to try to say, I'd like to find a program for myself, where are the programs for me? This triage tool, which will be embedded, hopefully, in the next month or two, will ask you questions about whether you've fallen recently, how confident you are in exercise, what kind of symptoms you're dealing with, and will then only show you programs that are appropriate for you based on your answers to this triage tool, validated triage tool. In the area of stakeholder awareness, empowerment, and engagement, we're really eager in the Moving Through Cancer initiative to ensure that everyone living with cancer is aware of the benefits of exercise. And so we developed with a whole team of experts, behavioral scientists and medical oncologists and, physical therapists, et cetera, a brochure. And our goal was to distribute those brochures and the associated postcards that point people to the online version through social media, through Texas Oncology, which is an enormous organization that serves millions and millions of people. And then we partnered with the National Coalition for Breast Centers in order, this is a picture of me standing in my booth in Vegas last year, getting ready to get signups for over 25,000 brochures going out to nurses across the United States to get the brochures into the hands of patients. We're in the process of translating the brochure into Spanish, we're working to see actually if we can translate it into Portuguese as well, because of my recent connections to Brazil. This is some of what the brochure looks like. It's intended to be in very plain, very simple language and to bring across some very simple ideas. And to point people to more resources as well. The screening survey and the directory are available by pointing your phone at the QR code. Simple ideas. Some movement is better than none. Movement matters. This is the primary message of the whole brochure. And then there are examples of how people meet the guidelines with walking or biking or ballroom dancing or swimming or many different ways of getting yourself moving. I will give a very short one-slide plug for my book, which is also called Moving Through Cancer. There is a website that's associated with it that has free exercise videos. In addition, there is an option if you buy the book to get 1 year free membership at something called My Victory, which is kind of described to me by others as Peloton for cancer survivors. So I commend all of that to you. But what I wanted to finish up with in the evidence side of things is a description of what we're doing for this Moving Through Cancer initiative, specifically at the Hillman Cancer Institute. So the overall goals of what we're trying to do with this program, the Moving Through Cancer program at Hillman, is to focus on current infusion patients. That's the way we've decided to start. That's, a group of patients to focus on. One of the things that's distinct about our program compared to other programs in the area and nationally is that the program is for all patients, just not just the very well. It's intended for everyone, meeting patients where they are and giving appropriate recommendations given current physical and cognitive abilities. Our overarching goal, what we set out to do, was to double the background rate of exercise referrals. So recall from one of my earlier slides that about 15% of cancer patients report that they have been referred to an exercise program by their oncologist. So what we're doing is we start with patient awareness with the brochure. So we start with the Moving Through Cancer brochure. We then offer a triage tool, the same tool that we're using online for the Moving Through Cancer program. And then we do a warm handoff to programming, including Cancer Bridges. So we identify patients at the second chemotherapy visit. We're doing the second chemotherapy visit because the first chemotherapy visit is a little overwhelming. We certainly will see people at the third visit if we miss them at the second visit, but that's just kind of our idealized triage process. The medical assistants provide the patients with an iPad that takes them through a validated tool to triage them. And then our rehab navigator comes over to speak to the patient on the same day in order to say, so it looks like you've fallen twice this week and you have severe CIPN. Based on this information, the recommendation is that you do cancer rehabilitation. I would like to help you by getting you a referral to physical therapy. Are you interested in doing that? So that's the kind of conversation that Andrew Chongaway has with the patients at Hillman. And the triage tool that we're using is a validated triage tool. We didn't just make up the questions. This is something that was developed through a Delphi process and validated. So a couple of outcomes from what we're finding. We've been doing this for over 6 months now at Hillman. We started on the second floor. We're now on the third floor as well. And, you know, the next step will be to go out into the community. And so about 20% of patients say, yeah, I'm good. They're not really interested in the triage tool. They're not really interested in hearing about the options for rehabilitation or exercise. And that's fine. We understand that. But that means 80% of patients are being triaged. They are receiving the triage tool. And so there are 3 possible outcomes of the triage. One is that they are sent to the community. We are referring them to Cancer Bridges. We are referring them to community-based resources and telling them that they should be exercising, but that they are well enough to go exercise in the community. And about 30% of the patients that we talk to fall into that category. We do find that about 20% of patients fall into sort of an intermediate zone called individualized. And what we mean by this is that these are the people who have some impairments, but there's nothing severe. Some individualized sessions would be really helpful to them, but they don't quite qualify for cancer rehabilitation. What we find is that fully half of the patients that fill out our triage tool qualify for cancer-related rehabilitation. So the notable findings coming out of this, we're doing this triage process and then connecting people with programming. And our net result coming out of this program is that 47% of triage patients are connected to programming. And I want to remind you that our goal was to double the background rate. And that would have been 30%, and we have blown right past it. And so we think that we have hit on something that we think could be really, really imitatable at other sites, at other centers. That this could be a really easy way to connect patients to an exercise program during their cancer treatment. So before I talk to you about some inspirational stories and then take your questions, I just want to pull together one slide for you that is about the complexity of trying to make exercise oncology standard of care in the setting of oncology. Right now, if you ask the average person on the streets of Pittsburgh, whether if their Aunt Betty is going through ovarian cancer, whether she should exercise, most people would answer no. They would mostly answer that she should sit, be quiet, and have a cup of tea, right? And so we have an awareness issue. So there are all kinds of ways that we can help with awareness. It's one of the reasons why I volunteer to do talks like this. I'm interested in increasing awareness. We need to figure out how to do referrals. That's what we're doing right now at Hillman. We're working on how to make the referrals to the programs happen. We also have to figure out how to define the workforce, who is appropriate to work with cancer patients to get them exercising. What kind of training do they need? We need to protocolize our programs, sort of like they have with cancer, with cardiac rehabilitation. And we have to define who is eligible for these programs. In order to get third-party payer coverage, we'll have to define who's allowed in and who is not. And then we need to ensure that programs are available. They currently are not. So we have a lot of work to do with regard to making exercise standard of care by 2029. I'm working as fast as I can. This is the Moving Through Cancer Task Force. It includes a medical oncologist, a behavioral scientist, an oncology nurse, a PM&R doc, a physical therapist, a policy wonk, and a partridge in a pear tree. It's a multidisciplinary group that comes together with great regularity to help try to move this agenda forward. And I'm so grateful to get to work with all of them. So now what I'd like to close with before I take your questions is a section I call What is Possible. This is a section about some remarkable cancer patients and survivors who have exceeded all bounds with regard to their exercise during and after their cancer treatment. So the first story is about Bill Jolly, who goes by Jolly, and he is. In May of 2011, a friend of his invited him to train for a triathlon, and he wasn't in great shape. This is a picture of Jolly spring of 2011. He's a ex-Marine. He had gained a little bit of weight, as you can see. A month later, he was just completely exhausted doing something and thought to himself, I know I'm out of shape, but I shouldn't be this tired, right? Later in the summer, he had what he felt like was chest congestion, nothing significant on a chest scan. But later in the summer, he was wheezing so badly, it sounded like he had a whistle in his chest. So his PCP ordered a second chest scan in fall, in September of the same year. And he said, it looks like you have an enlarged heart, probably nothing, but he's going to have a friend who's a radiologist review it. And the radiologist recommended a CT scan, which confirmed stage 3 lymphoma. His biopsy revealed specifically small lymphocytic lymphoma. And in beginning of January the following year, he started in chemotherapy, and he also started doing the leukemia lymphoma training, team and training the same month. He will tell you that he started asking at his very well-known cancer center where he got his treatment, where's the exercise program? And no one could give him an answer. So it's really typical, even in large cancer centers, there is not a program yet. We're trying to fix that. And so he was told to reach out to the Leukemia Lymphoma Society, and he did exactly that. And 5 months after chemo, he ran the Marine Corps Marathon. He then did an Outer Banks Olympic try in 2013, an Olympic try in 2014, and the Bull City Half Marathon in 2018. In 2016, he had a remission. And by January of 2017, he had increasing fatigue, growing significant. And his quote here is, I felt myself going to a dark place and I didn't like it. I didn't want to work and I didn't want to talk to my wife or kids. And after 4 days of increasing depression by the day, I told my wife at 10:30 p.m. I had to go for a run. And 1 mile into the run, my fatigue and depression just vanished. And I discovered I could keep the fatigue and depression away as long as I exercised every other day. And that fall, he ran his first full-length Ironman, or did his first full-length Ironman in October 2017. So his takeaways, and he only allows me to share his story if I share the takeaways, are listen to your body. You will know if something's wrong before the lab tests show it. If something feels off, don't ignore it. Be quick to get help from allied health professionals like exercise, nutrition, and psychology. Medicine and surgery are not your only tools. Exercise can reduce and or eliminate medication symptoms and reduce recurrence of some cancers. And importantly, exercise gives patients control of their lives back. That, more than anything in all of my years working in this field, is the biggest truism. Cancer takes something away from you. Exercise can give you something back. And the list goes on. Sydney Hooper is a pancreatic cancer survivor, Ironman competitor in Canada. Susan Helmrich is a 3-time survivor. I don't know how many of you remember the DES cancers, but she's a DES daughter. Also had lung cancer and pancreatic cancer. She's a master's swimmer still today. Gabriella Grunwald had adenoid cystic carcinoma diagnosed in 2011. While she had cancer, look at the size of that scar in her belly. She was a sponsored ranked USA track and field runner She placed fourth in the 1500 in the London Olympic trials while she had cancer, and was the national champion in the 3000 meter in 2014 while she had cancer. Gabe had a saying over her couch that was, there are two ways to live your life. The first is as if nothing is a miracle. The other is as if everything is a miracle. She clearly embodied the second. Mike Levine, great story, stage 4 pancreatic cancer patient. The left is a picture of him as a young man, as an Ironman competitor. When he found out that he had stage 4 cancer, he just kind of folded in on himself and sat on his couch. His friends, who were still, active and athletic, came to visit and thought, this is not okay, got him back on the bike, and he actually did one more Ironman before he passed away of pancreatic cancer, and loved every minute of it. And, the point is that he was completely capable of moving, even with stage 4 pancreatic cancer. Keegan Randall is a U.S. Gold medalist in cross-country skiing, and she was already a phenom in Pyeongchang for winning the gold medal in cross-country skiing, medal that generally goes to a Scandinavian country. And so that was already a phenomenon. In addition to that, she was a young mother. That was really remarkable, very unusual for young mothers to be in that position. And then she came home, and 3 months later, she was diagnosed with an aggressive breast cancer. And so she came and talked to us at the American College of Sports Medicine a number of years ago, 2019. And, she basically decided she was going to address her cancer the way she addressed all of her training. She rode her bike on the to and from treatments and stopped at the gym on the way. She tried to do something every day. She definitely had days when she could not do anything. Jolly and Keegan and Sydney all gave me interviews for the last chapter of my book. So if you are an athlete listening to me right now, you want to get the book and read that last chapter. It's about what it's like to be an athlete with cancer. She definitely had days when she couldn't do anything, but she tried to move every single day, all the way through. So what I would leave you with is that I believe it is time for a paradigm shift, that exercise is indeed medicine for people living with and beyond cancer, that a little bit goes a long way. It's not about doing an Ironman, it's about getting up off the couch and doing some exercise snacks. And I will thank you very much for your attention. And I look forward to any questions you might have for me. And I will stop sharing slides.